It's a great partner.
Yeah. You know,
Really?
Wherever you want, Paul. I have your ticket.
Everybody.
All right. You guys ready to get started? Good morning. Glad you guys all made it safe in this lovely weather we're having. I don't know that I like the temperatures, but I do like the snow. So it's a little chilly. So let's go through roll call. And we'll start with, we have Action Health Partners. We have Deb. Is Kaylee here? And Paige. Okay, AmeriGroup. We have Courtney and Kate. And Beacon. We don't have anyone for Beacon, do we? They're on my list. We just don't generally have them. Cascade. Kathleen O'Connor. Catholic Charities. We have Mr. Chris and Miss Chris and Shirley and Kendra. Right? I knew that was Susan, not Shirley. Sorry. Center for Drug, we have Paul and Loretta. Children's Home Society, we have Holly. And where's Courtney Fairbanks? Courtney's up there. Right there. Columbia Basin Family Medicine. I know Rosalinda said she was going to sign in. I don't know if Christina's made it online yet. I can. Thanks, Rosalinda. Columbia Basin Health Associates, Dulcie or Haley. Okay. Columbia Valley Community Health, we have Dave and Blake. Colville Tribes, we have Molly. Confluence, we have Dr. Colby. Coordinated Care, we have Amelia. See, I remembered. Cooley Medical Center, do we have Shoshana? Family Health Centers, we have Melody and Karen. Grant Integrated.
Mike and Gail are here.
Thank you. Lake Chelan, we have Jill. Mid Valley, we have Becky or Tracy.
That's right.
Thank you. Is Becky on also? I see Tracy online.
Yes, I'm here.
Thank you. And Melina.
We're here, and we have Laurel and Vicky on the phone, I believe.
Yeah. Laurel and Vicky.
Hello, good morning.
Thank
Good
you.
morning.
Is this like Community Health? I see Stephanie. And Sheila. Sheila's on the line also. Okanagan Behavioral Health. Do we have Lisa? Okay. Parkview Medical Group. All right. Samaritan. Richard on the line?
Yeah, Richard.
Thank you. And then we have the NCACH staff, and we have CSI, CCMI. We have Roger, Kathy, Christina. Connie online too? Good morning. All right.
Good morning.
Okay, for those I've missed, we have Rachel. This is a test on if I actually know your names and faces. I just want you to know. And then Susan and Kendra and Paige and Corey. Thank you for coming. Kate, that's it. I think we got everyone. Did I miss anyone around the table? All right.
This is Jim Wallace from Family Health Centers on the line.
Thanks, Jim, for joining us. Congratulations, by the way.
Thank you. I turned on my video, but I've got a high likelihood of a need to burp a baby here in a couple minutes. I'll save you guys
worries.
from that.
His son came early last week, I heard. Anyone else on the phone that we haven't called out?
Kathleen O'Connor at Cascade Medical.
Thank you.
And then Gwen.
Hi, Gwen. Anyone else? All right. Have the agenda in front of you. All looks okay. Do I have a motion? Accept. David Coldy, motions, a second. Second by Mr. Chris. All approved?
Aye.
Opposed? Okay. And now you have the minutes. They are short and sweet because we do not type up the minutes for what Roger's been doing. It was too complicated, and I felt sorry for Teresa. So we said, don't do it. If you're interested in it, if you miss a meeting and want to know what's been said, we do put those recordings up on the NCACH website for you to listen. And I actually do break his portion out of the entire meeting. So if that's what you just want to listen to, you're welcome to. So a motion to accept the minutes.
So move.
Dave Olson, and second? Second. Second by Jill. All approved? Opposed? Motion passes. I'm going to do quick announcements. We have a jam-packed agenda with Roger's portion, and then for your request, Dr. Marinkas has a presentation. It is recorded, and he'll be online about 12:15 for question and answer for those who are interested in learning more. Change plan. I'm looking at, I hope everyone is enjoying the view from the room. I'm looking at your lovely faces, so I just have to figure out how to advance the slides. Change plans. Thanks, everyone. Got them in. We did the scoring. Those were released, and those who had to submit rescores, thank you for getting those in. We should have the scores by February 15th, if not sooner. Also wanted to just say the MEHAP and the PCMHA, that was, some of you updated, some of you didn't, which was fine. You didn't have to if you had received full scoring. I just wanted to remind you that we will be doing those assessments annually. So whether you've done them with Gwen already, or we need to get those done, I'll get with Gwen to find out who has them done and who hasn't for future. Also, once the scores are finalized, we will be uploading the change plans to the portal, as we've talked in full transparency. And when we were talking about that, we had talked about in our minds, and I just want to confirm that it's the will of the group as well. It's the change plans, the letter of the support, and the PCMH MEHAP scores. Is that okay with the group? If you do not speak up or send me an email tonight opposing, they will be uploaded, and I will say it was the will of the group. Anyone online oppose that?
Wendy, can you clarify that?
The change plan, the letter of support, most of you submitted last June, July. Others updated it for December, as well as the MEHAP and PCMHA scores, depending on the type of organization and what scores you submitted. It was everything that you submitted in July. Some updated it for December. That will be uploaded to the portal.
For everyone to see.
I highly, you are welcome to go look at the change plans of everyone's. I just want you to know that we will be breaking it apart in future meetings, and I'll talk about that a bit, bringing in like the opioid group, the TCDI group, the hub, and the CHIs. And so those sections of the change, we're going to break out and kind of show you what others are working on, so you can see where you can collaborate with other organizations if they're working on similar activities. I don't see anyone saying no. Your chance. If you don't want to say no in front of the group, be that a lone person, feel free to. Reports, thanks for getting those reports in. We are working with CSI from the portal to get a aggregate report that we can then work with Tina, who's our improvement advisor, to send something back to you guys so that it makes sense and we can look and follow the progression of the WPCC and what we're doing. Pre-manage update. Talk about that. With the email.
Yeah, real quick, I sent all that organization to find out where you're at. A little bit, but I think I've heard from some of you about it.
If you did not receive that email, check your junk box or reach out to Carolyn because I think everyone around the table was at least CC'd. If it wasn't sent to you, you were CC'd. I did want you to be aware that there's the North Central Opioid Response Conference. Pathways Prevention will be March 15th. There's a flyer out on the table if you didn't see it. This is being organized through our opioids work group. Location is not on there because they are trying to find locations somewhere close to you. Mainly, they're looking at schools as well as other places. So more information on that, and I believe registration opens this week. There's an email there on the slide deck as well as on this flyer. You can contact Crystal for more information. And then starting March, I just told you that we're going to start doing updates from the other work groups so you can see how the WPCC links to other work groups as well. Any questions on any of that? Okay, there's the data look back on there, but we've actually incorporated that into Roger's discussion. So I'm going to go ahead and turn it over to him.
Great. I'll let you advance the slides if that's okay. There's a little quote here called, it says, attention is the currency of leadership. That fits into our talk today about in leadership, how do we support improvement? How can we accelerate the work? So I'm going to talk about a couple of aspects today. One is supporting the team, the quality improvement team, and then specifically something called senior leadership review, how to engage the team in the process. Next slide, please. So a lot of what we're talking about here is underpinned by something called the theory of improvement science. Embedded in that is the notion that organizations are systems. And in organizations, when you're running systems, you have to think about it in two levels. One is the day-to-day running of the train. And a lot of our quality improvement work is about keeping those trains running the way they were originally designed. They break down over time. They have entropy. They have external forces that come in. We'd like to figure out how to keep those trains running all the time. And then there are certain things that we do that are very strategic, like this initiative, the Whole Person Care Collective. All of you are participating in an activity kind of layered on top of what you're doing. There's a lot of intersect, and obviously you hope that all of this cascades down. But there's a famous story of the former CEO of Ford Motor Company when Ford was really in trouble in the 1970s. And they did what most management teams do when you're in trouble. You go on a retreat, and you have a few drinks, try to get a little vision, and you try to figure out what are we going to do. And one of the senior leaders as part of the team said, well, why don't we call the Japanese up and see if we can go visit and see what they're doing and how they're cleaning our clock here and competing with all these cars invading the U.S. Make a long story short, they ended up going over, and to their surprise, the Japanese agreed to host them. Said, if you can come over in this period of time, you can tour the different factories of the major automotive plants, and we'll share with you what we're doing, the future of what we see as the car industry. So they flew over, and the first factory tour, they were walking through the factory, and this mile-long assembly line, and Don Peterson, the CEO, looks down and just in marvel of the design of this assembly line. And then all of a sudden, a worker runs over and grabs this pull cord, and the whole assembly line slams to a halt. And all of the workers leave their station and start working on another station. He said, what's going on? And they said, oh, that worker over there noticed a defect. And so they stopped the assembly line before that defect can go on. And it's that job of that worker to figure out a redesign of that defect. And all those other workers have their own projects. So they're all working individually on improving their car. And they had baked in improvement work into daily work. It was a psychology. It was a set of tools and skills every employee was taught. And when they got back, Peterson, asked them, "Why would you be willing to share all of this with us? I mean, we're your major competitor." And they said, "We feel we are so far ahead of you competitively, you will never catch up." And in part, it was because of this baking it into daily work. Now, that's going to be significant when we talk about how do we do work. On the slide here are the different types of teams and organizations. I was asked to talk to the Quality Affinity Group as part of the Whole Person Care Collaborative. I think some of you may have been on that webcast call. And it was very clear on that call that there were different levels of teams on the call. There was a team that was working on this project and trying to figure out how to execute the change plan, so that's kind of at that level, right? And then there are other teams that are frontline care teams, where people are working as a integrated unit on a pod. And then there are quality improvement teams, where they may have multidisciplinary people that have come together in some fashion. So in organizations, we use lots of different vehicles to get people to work on things, but unfortunately, this is one of the most poorly used resources. We have meeting after meeting after meeting, and what we don't do is really see how can we optimize those meetings. Are the teams really working on the right thing? Are we removing the barriers to accelerate the work? Can we free up time by getting rid of unnecessary meetings, unnecessary work groups? And all too often, organizations expand by having additional work placed on them. So part of our role in leadership is to make these much more. We're doing a test here. I'm on Zoom and in the room. So we'll have to turn off. Something was turned on. Or am I the only one hearing my voice twice? Okay.
What voice?
Can we switch to the behavioral health topic then? Okay, we'll try. Mine is muted. All right. Well, let's try to talk over. If you'll bear with me. Oh, it disappeared. Okay. If you're able to hear me in the Zoom world, can you just shake your head? I see some people. No, they can't hear us in the Zoom. Is the sound off? Are you able to hear from the Zoom world? Yes. Okay. Good. Okay. Thank you. So, in optimizing these different types of meetings when we get together, there's a whole series of different tools we can use. There's something called the 7-step meeting method. I'm going to send a handout to this group for next month's call, and we can talk if you want to go down into that. But it's a methodology to try to really optimize team time. There are group dynamic tools that help manage conflict and creativity, something called the 6 thinking habits that we'll share. I'm going to show that to you in a second. And the whole series of brainstorming tools that help manage and infuse creativity, but also help constrain. Can we move to the next slide? So one of the tools that we're going to talk about, and for those of you that have groups on the empanelment series, we created a little bit of a fire by introducing this concept and suggesting that the tools, the teams that are working on empanelment, think about using a storyboard to communicate internal to the organization. So for those of you in leadership, if you hear people coming to you saying, "Wow, we want to use a storyboard," this is the context. So storyboards are often used to go and communicate improvement projects at meetings, national meetings or gatherings like this. I think we used a storyboard at the kickoff, where all of you were asked to give a little bit of background on your organization. Same concept, but a storyboard can be used as a living diary to follow a quality improvement effort. It is very helpful in communicating to others in the organization what is happening, what are the changes that are coming about, and to solicit their input. So this is an example of one storyboard. I think on the next slide, I think I have another example of a storyboard. This is another type of storyboard. This is borrowed from the Lean field called the A3 report. It's a standard structure that can be used to follow the journey of a quality improvement project. So typically, there's a clear articulation of the problem and data on the problem. There is information on root causes, what we have identified as root causes, and any data to support the root causes. What the recommended interventions are, what we're testing in terms of these PDSA cycles, and what we're learning from the PDSA cycles, and then ultimately recommendations for the organization. So if this is populated over time in an organization, it can really help bring the rest of the organization along, and you're not suddenly dumping surprises on people. Next slide, please. This is an example of some of the group dynamics tools. These are the 6 thinking hats. Again, I'll go into some depth perhaps on the next month's meeting. But basically, this is an opportunity to take a issue and talk about it from different lenses. What objective data do we have on the topic? What feelings do people have about this particular issue? Let's take a very Pollyanna hat, a very white hat. Let's take a negative hat and look at it. And let's get all of that information out and then step back and do the so what. And that can be a very powerful technique. And again, we'll get into this a little bit perhaps next month. Next slide, please. So the main topic I wanted to talk about is something called senior leader reviews. Now, this is generally in the context, if you're in an organization where you are using a team-based approach to solving problems. You have a quality improvement team working on safety or quality improvement. If you're a real small organization, it probably doesn't apply as much because your leadership might be part of the team and you're all part of one group. But some of the concepts may apply in terms of the discipline of the process. So in doing a senior leadership review, these are done generally at milestones that are set up at the beginning of a project. So if you're putting a group on, let's say that there's a group that's going to tackle asthma. We've been talking about asthma for a while. You charter a team, say we want you to work on this and come back with recommendations and changes and PDSA cycles on how you've improved asthma for a group. A senior leader might want to set a date. We'd like you to come back in 6 weeks and be able to present to leadership what you're learning from your process. You're not finished yet, but we want to benchmark along the way and learn from you in that journey. In some organizations, you might be very, very large and very dispersed, and it might not be as practical to get everybody together in that sense. With virtual technology, it's much easier to do that now. But some groups have used their quality improvement committee, their QI committee, to often play that role, with a caveat of being critically important to have senior leadership on the team when those reviews come. Again, this gets back to that issue of attention as a currency of leadership. If we don't have leadership participating in that process, it's a very clear message to the teams that this really isn't that important, despite what we've said in terms of our public messages. Again, using the storyboard is a key tool. Some organizations have an annual quality day where they showcase different storyboards. Quite often that's done in October, which is National Quality Month. Why October, I don't know. But it does happen to be the month they announced the Malcolm Baldrige National Quality Award winners at a national level. And a few groups have special quality events. Like there's a Hospital Quality Week, the second or third week of October. Just something for information. Next slide, please. So a senior leader review is where the leadership can keep things on track. If the project's not achieving the results it's achieving, it can ask why. Is this an issue of lack of organizational will? Some of that organizational will for a larger organization often comes from mid-level managers who have not bought into this change that's suddenly been imposed, who may not have been included in the process and are resistant. So if you're having troubles getting access, for example, in the empanelment sprint that we're working on, part of the process right now, they're having to get data from their IT department. And that can be a challenge. So if they've gone to IT and IT says, well, I can get it to you, but it's probably going to be September of 2021, that's not going to work. And that may require leadership to intervene. That often doesn't bubble up to leadership. It becomes a stumbling block that can be uncorked very quickly. But if you don't check in and know, then it's off the table. Sometimes there's a failure to just execute some of the changes. They tried something, it was a belly flop. And there may have been some nuance with the execution strategy that is leadership. You can help advise and coach and try another permutation of that. You'll find that that helps the court process. And sometimes you have to decide that this group's been working on this, and they're getting nowhere. This is the euthanasia concept of, you know what, let's just put people out of the misery and let's just reform another group, or let's figure out what we need to do with. Next slide, please. And so the senior leadership has some pre-work, and then there's actual meeting process where you review the aim, you review the measures, you review the trends of the data. This is a key phase. A lot of times groups will get together and go right to the answer, and they haven't done the homework on the root cause. They haven't done really the data piece of how do we know this is the right thing to be working on. So making sure that that's a disciplined process. Try to identify barriers that from the team, from the group. And doing a little bit of failure mode analysis, predicting where things are going to break down ahead of time, trying to build that in where possible. And then always thanking the team at the end for their work and making sure that you are able to then tee up what's the follow-up. This is what I will do in leadership, or this is what we will do in leadership. We're going to follow up with you in 6 weeks. So you identified these 2 barriers. We're going to work on that. And this is what we expect you to be doing over the next 6 weeks, 8 weeks, and the next milestone. Next slide, please. So that just kind of puts a wrapper around this notion of senior leader reviews. So this is an opportunity to formally check in on a project, making sure it's not straying, to help self-correct, help make sure the groups are getting the right attention and resources, and then to be able to align that across the organization. A colleague of mine was the CEO of a primary care system in South Carolina, and she talked about one team where she learned the importance of this. The team had been working for 9 months, and one of the staff members came in and said, I'm quitting. I can't take this anymore. I can't take this project. She said, what are you talking about? I said, well, we have been working on this measurement and putting all this data into the electronic record, and it's not sustainable. Said, what are you talking about? So this organization had an electronic record, but they had developed a register of their patients. For some reason, the staff had assumed that everything that was in the electronic record had to be put into the register. So they were hand putting all this information that was an hour per patient. Appeared so far off track from their original mission. But she got very angry, and her reaction was getting angry at the team. Why have you wasted all this time and energy? But she realized that she was actually angry at herself because she had let this group just flounder without checking in on the process. So that's really the power of senior leader reviews, just to monitor and check in as part of the process. Anybody do these senior reviews currently in your organization? You do? Any comments or observations for the group?
The A3 shiver.
That's all you do is
A3s, 6
Shiver in a
ads.
good way, or?
Not in a good- They're a lot of work.
It's work to be disciplined and making sure that you're capturing the right information, and you have to monitor that. Sometimes people get caught up in the tools and not the substance, and that's something that we have to make sure we don't go overboard as well. Any other observations? Any questions? All right. Well, let's shift to data. And we've suggested a couple of months ago that we would start to look at your data for the region, try to identify where there are opportunities for collaborative effort across the groups. We challenged organizations to go and see what data they have. Several of the payers have come forward with some data. I think we're waiting for a third payer to come forward, and then all of that information will be synthesized and brought back to you. Hopefully we can have that by the next meeting. But based on some of the questions you had at the last meeting, Caroline and staff have gone back and tried to drill down. So she's going to present some of that information, and then hopefully we'll have some time for dialogue. We're going to be short today because we have a guest speaker coming to virtually and a presentation, but we will carry this over into March. And hopefully by March, we can put a wrapper in terms of all of this data and some of the priorities. Caroline?
So, Roger, it strikes me that we're doing a little bit of a senior leader review right now with this group to see if we've veered off track with our focus on asthma. So I think we started hearing a little bit of pushback. So part of the data that we're showing today is to try to make an informed decision about whether asthma is really something that we want to align across the collaborative. We guys are working online with your organizations, and we're trying to find alignment across the collaborative. So hopefully some of these slides will help. So I think when we looked at some of the paper performance data, which kind of showed where we were weaker and showed some areas around asthma, that was kind of focused on impact. And there were also indications that asthma is in our area, and I'll visit some of that. But I think some other things to think about that we thought about with other work groups as we were looking at target population is, the capacity, the capacity to work on this, the need for your population. I know some of you have said, well, this is really priority for us. And then synergy too, is this an issue that is shared across the whole collaborative, or is it mostly that a few of you are really taking asthma, but the rest of you prefer to prioritize other chronic? So just putting this up there as some criteria to think about as we think about a cross-collaborative effort. So we started discussing areas where we might create alignment, and this is the first iteration of the paper performance data that we received. And these measures that I put up there, I just pulled out the ones where we were below the statewide average or the lowest performing state. So this is a slide you've already seen. I've just condensed it just to show you that these were areas based on the paper performance metrics where we might want to focus as a collaborative to improve these measures. So that was in October 2018. And then in December 2018, we got updated data, which was like a 6-month shift in the measurement period. And in doing that, some of the measures dropped off, but the ones that are bolded here are the ones that remain, still like the need around. And asthma was on there both times. And there's also some areas where we could improve across the region on antidepressant medication management, mental health treatment penetration. And some of you asked us to look back at the community health needs assessment data to see what it said about asthma and whether it should still be a priority for our region. So I wanted to bring this back. Some of you may have seen this in other work groups, but on the left-hand side is some ranked priorities based on interviews that were done or surveys that were done for people who participated in the TINA at that time. And you can see that mental health care access is the top priority. Asthma didn't particularly come up as a priority, but in one of the appendices, I pulled out a little chart on the right that shows that the asthma was included as a potential health need due to the increasing prevalence over the past several years in our region. So that's just a look back at the community health needs assessment. And then for our chronic disease project, when we as an ACH submitted our project plans to the Healthcare Authority, we did, you'll remember, pick 4 potential chronic diseases that you all could focus on. So diabetes, respiratory issues, cardiovascular issues, heart disease, and depression. And some of the other data slides I'm going to share here are just some of the background work that we had done with some of the data sets that were made available to us. And this was data that we shared with the WPCC work group. And this is just to show you why those 4 kind of broad chronic disease areas were chosen. I'll let you kind of digest what's on the slide right now. But respiratory infections were the 4th most common cause of hospitalization in our area, which compared to the 9th for the statewide average. So that just seems to indicate some kind of need around respiratory issues. Additional data we received from the Healthcare Authority, and this is just ranked in order of prevalence for our region. This is for both, this is based on patients who are served by both the Medicaid and also the DSHS side of things. So it's not just Medicaid specific, but you can see that major recurrent depression was at the highest prevalence in terms of the disease grouping, which is what this data was based on. And then also second is pulmonary low, which in this case is viral pneumonias, asthma, COPD. What the color? What's that?
the colors that
So the colors are hotspots, so they're shown within each of the Medicaid eligibility groupings. So each column is based on an eligibility grouping, and within each column, we're hotspotting the highest prevalence. Yeah. And then additional data on ED utilization, since reducing avoidable ED utilization is such a big theme of the Medicaid transformation, we pulled out some of those same CDPS disease groupings, and we're showing here these likelihood ratios, which are, I'm going to admit I struggle to interpret at times, but basically the odds that people exhibiting a certain condition also have another condition. So if you look here, it just shows that people with 6 or more outpatient ED visits in a year, which are the red boxes, were 7 times more likely to have type 1 diabetes or bacterial pneumonias or chronic obstructive asthma compared to those who didn't have 6 or more. So it's like a weird kind of construct, but I think the takeaway is that in terms of things that might be addressed in outpatient settings and reduce outpatient ED visits, diabetes and asthma were up there. So last time you asked about the numerators and denominators and the population change needed for these P for P metrics. And specifically, I forget who asked, but you wanted to know, so how many people are we talking about for that asthma measure? So if you look on this slide, you'll see that for the medication management for people with asthma, in the numerator for our ACH region, there were 170 people out of 627. And I think the denominator is based on people who were diagnosed with chronic asthma. And I can pull up the measure spec if you want to go there. But I'm sharing this data here because I think this adds to the question of impact. Like, how do we think about impact? Do we want to think about the volume of people or where we're the lowest performing? I mean, there's many ways to think about that. And I think what we brought this data back to you for today is to continue to question whether asthma is really the priority you want to focus on, or whether there might be another area where there might be more synergy across all of you, and where we can have an impact. So that's it in a nutshell. The following slide, which is also in your packet, is just the additional measures. Again, you can see all the numerators and denominators. But any questions? This is just food for thought. And then, Roger, maybe you can help kind of facilitate some thinking around,
If
how
you
we
could
want
back up one slide.
Yep.
I'm doing some work in Louisiana, and the Secretary of Health briefed a group like this that we have one of the highest recent rates of growth in STDs of any state. And the audience kind of looked. She said, 70 people. She said, I can hire a full-time nurse practitioner to go around and medicate all those people. We'd be done. So that's manageable, 70 people. So when you talk about, trying to tackle an issue, I bring that up because when you look at asthma, if we're talking about 173 people as the numerator, and you only need to move 14 to keep you from losing your pay for performance compensation from the state, that seems like something that could be tackled. If you're talking about 20,000 people, you have to figure out how to reach. But that seems, with the collective will of this group, a number that could move, and is very manageable. I don't know. I throw that out to the group, but I challenge you. So, based on what you've heard, and anything pop out, or any insights or other thoughts?
I think we need to revisit, or on an ongoing basis, remind ourselves of what the purpose is. Because if it's to make sure we don't lose that money, then bingo. On the other hand, if there are 20,000 people with an issue, and we help, only 10%, we just help 2,000 people. So I think sometimes we just need to say, okay, what is it we're trying to do, and how does that align with which projects we take on? You're right, sometimes they're just so big, where do you start? But I would measure that against how many people can we help improve their lives.
And may take very different pathways in terms of how to solve the problem. Other thoughts? Anybody in the Zoom world? Any reflection? And again, there's nothing conclusive here yet. We're still waiting for additional data. But yes, someone was going to say something.
This is Sheila.
Yes,
Is
Sheila.
is that data that we're looking at for adults and youth?
For the asthma measure?
Yes.
I believe so, but let me look that up to be certain, Sheila.
Okay. You know, from the community health centers, appropriate use of medication for asthma is something that we currently work on an annual basis and report HRSA on the adults. So, you know, we have a goal in Moses Lake for ourselves, and it seems like the work would tie in well to what we're trying to do at an ACH. If we're able to, you know, drill down on the numerator and the denominator.
And Sheila, I'm looking at the metric description, and it is percentage of Medicaid beneficiaries 5 to 64 years of age.
So we can drill down on this data, can't we? And who the members or who the patients are? Are we able to do that with this?
There's a way to do it, yeah, on the Healthier Washington dashboard. You can drill down, but not in terms of numerators and denominators. So figuring out who's in what age grouping, we're not able to get that.
That's
Anything else standing out?
This is, sorry. Oh, hi, this is Laurel from Molina. I was just going to say that, so med management for people with asthma is one of the measures that the MCOs also are tracking as one of our contractual obligations. And MCOs would be able to give their, or at least Molina would be able to give our participating primary care practices the specific individuals who are missing or showing a gap in care.
Perfect.
Work pretty closely on our change plan, and we were, of course, tasked at the beginning to pick a chronic illness that we were going to be tracking on, and we did diabetes because we're a mental health organization that offers antipsychotics. If asthma had been initially the thing that we were supposed to track on, we would be tiering and making, interventions for that, and now we're kind of coming behind, and I'm going, oh my goodness, I mean, yeah, we're checking whether our clients have asthma. We have no asthma plan in the change plan. We're not caring for it. We're not paying attention. We could be, but it's a little bit, now we would have to go back and reorganize everything that we've done on chronic disease.
Last time we talked about this diagnosis of asthma being a question, really whether it's a true diagnosis or somebody gets an albuterol inhaler for reactive airway disease because it's smoky, and then they only fill it once and they're fine. They fill it again, but they've got this diagnosis hanging on their chart that fully skews your data. So I can just say confluence is not going to work. This is important to treat people with asthma appropriately, but I think getting the appropriate diagnosis is still important. And I feel like this is adding yet another project, and we can't use that project.
Right. Yeah. And so I think that's a question, right, when we're thinking about how many, what is the common thread across all the change plans maybe that you guys already chose to work on the front end, and that wouldn't require backtracking. And I think there's probably, depression is a big theme, training for depression.
You'll get next page.
Tell me the next slide, David.
The greater than 90 NEDs.
Opioid therapy.
That's a hard number, whether you have diagnosis or not. People are getting that prescription. Everybody knows.
One of the discussion points, and hopefully we can bring this to the table next month, is there's timing issues. I think the colleague just stated their change plan and your priorities are different set now for the year. This would be an add-on. But is there the possibility that we should be looking at perhaps some parallel tracks for those that have a common interest on asthma that are already aligned with their change plan and what they're required to report externally? Maybe they be working on those issues. Some others working on other topics, the depression management, opioid issue. And then perhaps is there one item that might transcend all organizations, something that could be done leveraging what people are already working on, but in a much more collaborative fashion. We're leveraging the collective resources of the payers, the delivery system, and the community-based organization. So I'll plant that seed now for discussion next month, but I think David has thrown out the opioid opportunity as one certainly high on many radar screens to consider. Any other points or thoughts?
Who's the status?
This is
I have a things I just want to bring up. So going back to slide 21, where we did the comparison from October of 2018 to December of 2018, all of these on the December 2018, with the exception of the follow-up after ED visit and the medical management for asthma, we have no control over getting that data. So it's hard for me to make any type of changes if the state is not giving me that data. If the insurance companies can start helping us get that, that would be great. But I have a hard time making changes for things I don't know that I'm having a problem with. That's the first problem. And the second thing is, I understand where Confluence is coming from. It's like one more thing. And one thing that we are doing in the TCDI workshop is, we looked at Confluence because they really had a program down. And instead of having to reinvent the wheel, we asked them to show the rest of us pilot their program. Why can't we do that amongst ourselves? If Sheila's group in Moses Lake, if they're already reporting this to HRSA, they probably already have their program down pretty well. Why can't we look at everybody's and adopt somebody else? That would definitely take the load of the work off of us.
So that proposal is this kind of sharing of best practice approaches to addressing an issue in a particular domain. And I think that's I think it's a great idea, and that's what's suggested why we're having this discussion. How can we leverage that? If we can pick the topics, then we can identify who are the high performers in those areas, and then share those best practices and figure out what could be done to systematically improve that. Someone else who's making a comment virtually?
Yeah, this is Jim Wallace from Family Health Centers. I like asthma because, so in our experience, we looked at our initial data on asthma and found the same thing, which is that a lot of people are getting prescribed medications like albuterol or corticosteroids and might not necessarily meet the definition we really want them to and shouldn't be diagnosed truly as having asthma. And so there's a challenge of getting the data right. And that led us to really improve our data collection, analytics, and diagnosing on a provider level. I think asthma also presents us with the opportunity to work on provider support and decision-making around diagnosis and prescribing medications, but also to bring our teams into it, especially with prevention and looking at developing asthma action plans. That's something that our MAs and other staff members can support us in, and so it's an opportunity to build teams around one of these challenges. It also, I think, asks us to bring in social determinants of health and look at the environment, social situation that folks are in, because asthma definitely adversely affects those with less access to healthy resources for health. And so in just some of the preliminary work that we've done, I think, we've uncovered a lot of opportunity, and it'd be a interesting project to kind of expand on. I think we definitely need some support in developing a good way to track the data and run some of these more robust quality programs with it.
Thank you. We have a comment from here in the room.
I had a question.
Go ahead.
The data is just the Medicaid data is all population.
The metrics,
Yeah, the metrics here.
it's
Based
mostly all
on-
Medicaid, but some of it's a little bit broader, but it's not the whole population. Well, many of the data sets that we get from Healthcare Authority are Medicaid specific. They can exclude dual eligible.
So I'm sensitive to the time because I know we have a hard stop. So we are proposing that we'll bring the last data set, which I think is from the payers, hopefully for next month. And at the same time, go down a little bit more and see if we can make some recommendations on an approach. Weighing in. Feel free to shoot any emails in between or any additional suggestions, comments, or questions.
So we have the presentation from Dr. Benriquez. It's a recorded presentation. So this is a first for us. So if you, in the Zoom world, as Roger would say, can't hear, please let me know. We'll start it now.
Hello, my name is Luis Manriquez. I am an assistant clinical professor and a family doctor at the College of Medicine, and am leading the work creating the mobile clinic. So this mobile clinic is, well, first let me start with WPCC College of Medicine Community Medical School. So we have 4 clinical campuses in their first 2 years in Spokane, and then they will go to either Vancouver, Everett, Tri-Cities, or Spokane for their clinical practice. The mobile clinics are part of the practice plan for the College of Medicine that is being developed, and we currently have funding to create these mobile clinics, particularly at using the Spokane area first. So this is the results of our needs assessment, which was put together this summer by myself and 3 medical students, Ashley Carly Celebrezzi, and Megan Olson. So I just want to go over our findings and then talk about how we could collaborate with providers in the North Central region. So here's how we went about the needs assessment. We had an online survey followed up by in-person phone interviews and group presentations. We also worked with the Spokane Alliance to identify needs specifically in the Spokane region. And then we looked at other needs assessments produced by the Washington Health Access Association. So we partnered with the Spokane Alliance. Their work, they did listening sessions with their member institutions, churches, unions, community organizations, because they are what needs they see. So we focused around the Spokane Clinical Campus. You can see there in yellow is the area that we focused on first. So those counties: Okanagan, Douglas, Grant, Adams, Lincoln, Spokane, Berry, Monterey, and the Spokane, Kalispell, Colville, Portland tribes. I will talk about Chelan in a second, because I know that's part of the North Central ACH, but it was not initially part of the. So the way we went about this needs assessment, the people we were trying to talk to were our different stakeholder groups. We wanted to get a sense from multiple points in the community how we might be able to provide support with mobile clinics. So we talked to the Department of Health, the Extension Office, school districts, local government, medical providers, social service providers, community organizations. The responses that we had overall, and then I'll talk about each of the North Central counties individually. So we had 131 responses for an online survey. That online survey was sent out to people that we we had identified and contact information for, and then we asked them to send it to anyone who might be interested in filling out the survey. So we don't have a complete assessment of all of these regions, and we're sort of dependent on the word of mouth along with that group partners like the ACHs or the health to make sure that the survey got out. So if it didn't get you, I apologize, but we are continuing to have conversations. So anyway, to overview, 131 responses, followed by 34 phone interviews and 8 community presentations. This would be the 9th with the Health Coalition, actually, for the school. So what we found in Okanagan, we had 31 responses. This was the biggest response rate we had outside of Spokane County. Issues that they had found were services that were hard to meet, mental health, and treatment for alcohol, opiates, and other drugs, access to specialty care, and primary care across the age. Leading preventive service gaps were substance use screening, dental screening, and diabetes eye care. And leading social determinants of health that were identified as contributing to health issues were housing, transportation, immigration status. Just an example of something we got from one of our phone responses. Okanagan is the largest county in the state, 5,200 square miles with mountain passes. It can take 2 hours from one end of the county to the other, and doesn't even include the people who choose to live off the main drag. We're not just rural, we're more here. I know the Colville Reservation covers Okanagan County. From Colville, we had 5 respondents. Primary barriers they saw were for the elderly population, access to care and immunizations. Hard to meet services they identified were dental care. Many respondents indicated this was an issue, particularly outside of areas where the clinics are. And then leading social determinants of health, again, housing, transportation, discrimination. Grant County had 9 respondents, plus we went to the Health Coalition meeting in Grant County. Issues they brought up, again, treatment for drugs, opiates, and other drugs, opiates, treatment, specialty care, mental health, and primary care for those over 18. I should say that other drugs essentially mean methamphetamine, because we asked about alcohol and opiates. Leading preventive service gaps, dental and substance use screening, leading social determinants of health, and these are pretty consistent throughout all the counties: housing, transportation, immigration. So in Grant County, demographic trends suggest that health inequalities in our growing county will continue to increase. The fact that our county is so large makes it difficult for folks living in remote areas of the county to access medical care. Mobile medicine could make a huge difference for some of our communities, bringing the care and education directly to them. And there was also noted the split between West and East County in terms of demographic. In Douglas, we had 5 respondents. Hard to meet services, dental, and I should say for dental, it's all for the adult Medicaid population. Those were the groups that had the biggest issues. Mental health, treatment for opiates, other drugs, and alcohol abuse. Leading preventive services, dental, substance use immunization, particularly HPV, social determinants, transportation, immigration status, housing, food, insurance. One of our respondents, this is what we heard, not our opinion, is that there's a discrepancy between what is offered and what is desired. Providers do not understand the culture of poverty and therefore do things like tell a client to use a humidifier when the client is in the garage. I did want to talk for a second about Chelan. Chelan was not originally included in the needs assessment service area. Having talked with the ACH, they asked that we include it, and so from that point forward, we did send out surveys to people in Chelan County, school districts, social services, and through the North Central ACH, it was sent out to providers. We did not have any responses. The way that we are actually going to go about incorporating Chelan, so these regions are part of the needs assessment, but in actual service area, it's likely that the east side of the county will be included in the Spokane area, the west side in the Everett service area, because those mountains make it very difficult to get there from Spokane in a timely manner, And the South County may be included in the Tri-Cities service area, trying to really cover the valley and the communities, the makeup of those communities there. So there may be some changes in this map. Either way, we'll be doing more assessment of Chelan with the next round of the needs assessment, which should hopefully be the Tri-Cities area and hopefully this summer. And the mobile clinics, I should say, will have an integrated record. So it's not as if there won't be an ability to communicate. It's just going to be which unit based in which area is going to come out. And so that may be particularly important when we talk about the valley and the need for to prioritize providers and staff that speak Spanish. May make more sense for Wenatchee to be included in the Tri-Cities area where there's more of a need for Spanish population and services. We can make sure we're addressing needs directly. So just to give an overall picture of the entire needs assessment area, because we did find lots of things to be fairly, the problems in rural counties to be fairly consistent, I should say. So we broke up all of our responses by Spokane, by rural counties, which is all the counties minus Spokane, and then the total, so you can get a look at how those differed. So the first question we asked was around social determinants of health. Which issues are affecting people's access to health care or their health directly, but not through a healthcare mechanism? And overall, housing was the number one, and then transportation and insurance. Housing, transportation, and insurance were the big problems everywhere. It just mattered which order they were found in. That percentage there is that in Spokane, 73% of respondents had mentioned housing as a social determinant of health that affected health, and in rural areas, 88%. And these social determinants, in many cases, rural areas' response rate was a little bit lower. They pointed out less problems, except here in social determinants. So I think it's fair to say that transportation in particular was something that was widely and broadly felt, and that speaks to the value potentially of having a mobile clinic that can come to people where they are. Barriers to primary care was the next question we asked. There was no real difference between age groups, so there wasn't a difference between access for children versus adolescents versus the working age population or the Medicaid population. But the major barriers that were mentioned again were transportation costs and access for Medicaid patients in particular. But as you can see in Spokane rural and the total area, there's very little difference between working age adults, young adults, and infants and toddlers in rural communities, and in total there is a little bit less sense of need for infants and toddlers in Spokane. We also asked respondents what services were hard to meet, and if you combined substance abuse, so we asked about substance abuse as alcohol, opiates, or other drugs. If you combine those responses into one response around substance abuse, that would by far be the most needed treatment overall, and in both Spokane and rural results. So there was at least the perception that there is a lot of need for treatment of substance use across the region. In rural areas, mental health first, then opiates, then other drugs, and other drugs is essentially asking about methamphetamine. And then if you look overall, it's the same thing, mental health, other drugs, and opiates. They switch places, but they're essentially tied. So there was a little bit more concern for meth in the rural counties and then in Spokane, but they're essentially equivalent. We asked about barriers to immunization, and we were asking about age groups to see if there was one age group in particular that stood out for needs. When we asked about barriers to immunization, we actually had our lowest response rate, and we think that was for a couple of reasons. So when we look at the health department data and we look at how Washington compares to the national average, there are certainly we're certainly not doing fantastic in terms of immunizations. And so this low response rate, how did we explain that? And we think that many respondents didn't feel qualified to speak about immunization rates because many respondents were not actually healthcare providers, but as I said, were coming from education or the extension office or community members or local government. And so that's why we think these response rates were lower. In Spokane, infant and toddler need was greater, and that's probably because we talked to a lot of the early Head Start organizations. And in rural areas, sort of K through 8, infant, toddler, and adolescent, we're all kind of sharing as the top 3 needs. So preventive services, we asked them what preventive services were most lacking or hardest to address. And dental came out number 1 across all areas in terms of access. And this is, I should say, primarily for the Medicaid adult population. So there are services available and there are efforts to try to do referrals, but there's just more need than available for lots of reasons, what we've heard in terms of Medicaid population. After that, substance use disorders, both screening and treatment, were strongly needed across the region. The diabetes finding refers to an annual diabetic eye exam, and I suppose we could talk about a foot exam as well. So those dental, substance use disorder screening, and diabetes were the highest rated concerns in rural areas and also in as well. Some special considerations that were also brought up were family planning, reproductive health, and STI screening. So those issues, I think, were primarily focused around youth. So overall, recommendations that we had put together for the whole of our needs assessment for the board in determining how we're going to build out these mobile clinics. So the mobile clinics will need to go into the rural communities, not just to the biggest city within those counties, particularly through collaborations with schools. Everywhere we went, we asked what is the natural gathering place by which we could get to families and communities, and the schools were number 1 across all regions. It's going to be very important that these mobile clinics have an integrated EMR so that we can connect with existing providers in the communities and be a care extender and not duplicating services or, in some way competing for provision of services. The mobile clinic should not turn away anyone due to cost or insurance. So cost came up as a big issue, and it came up as a big issue both in terms of transportation to the clinic and co-pays and people who are uninsured. So trying to remove that barrier was one thing that we think would be valuable, particularly for low-income populations. Substance use screening and treatment are pressing healthcare gaps. So those are things that we need to make sure that we are addressing in some way through a mobile clinic, collaborating with local providers to address. And then mental health support is needed throughout the region. A couple more recommendations. Dental care for adults should be coordinated into clinic services. We are a medical school, but there's definitely a huge need for dental care, and so we need to figure out how we integrate oral health with the rest of the body. And then the clinic should be equipped to do diabetes eye exams. In lots of areas, the distance required to travel to get a diabetes eye exam was brought up as a reason why people weren't getting them. It's fairly easy to do that with a scanner that could be brought to a community center or so that was one of those recommendations. And then lastly, the clinic should help coordinate access to specialty care. And there are multiple ways we could go about doing that, but try to help people who may have a local PCP, but then if they wind up needing to go to the rheumatologist or the cardiologist, they wind up becoming patients of Spokane or patients of Wenatchee, and those distances become much more difficult. So that's all of our recommendations. I did want to talk for a minute about next steps, and then hopefully we'll be able to have some questions and comments and feedback from you all. So next steps, we have to build out these mobile clinics. We're awaiting some board and institutional decisions to help launch the practice plan, which will allow us to spend the grant funding that we have to build these clinics. So I do not have a direct timeline for when those clinics will be built, but our goal is to have them up and running at the beginning of the next academic year, which would be in August of 2019. We need to establish our integrated medical records. So we do have an innovation center at the College of Medicine, and there are multiple technological solutions to integrate whatever medical record we are using at the college with local records so that we can transfer information back and forth. And we also need to work on developing collaboration agreements with community partners so that it's clear what role we're providing and what pieces, how we can plug back into existing medical services in the regions, and then developing the clinical calendar and schedule and cutting those logistics. So, in terms of services that we're intending to provide, we are awaiting final plans on the outline of services from the board and the dean, so I cannot make any guarantees, but the areas of focus more generally will be that we are able to take care of urgent care needs, that we provide preventive health screenings, so the diabetic eye exams, foot exams, potentially wall child checks, immunization, reproductive health screening, and like blood pressure. Then dental screen and referral. So the need for dental care could be addressed through potentially building a dedicated dental unit. The decision about when we could do that and to what extent we could develop that unit still needs to be made. But at a minimum, we will be developing the capacity to do good oral health exam screens and referral to local providers, working with our Cora Foundation to make sure that we're letting people. And then lastly, the ability to address mental health and substance abuse. So we have quite a robust research department at WSU around substance use and mental health, and we're looking at several different funding opportunities to provide telehealth and support services for the treatment of both mental health and substance abuse at the local level. So, it's not possible or useful for a mobile clinic to come in and provide counseling, once a month, or talking to people about their substance abuse once a month. But how can we use the resources of the university to support and backstop what's going on locally? And so, we are working on developing those plans. I would love to hear from you all how that might most usefully be deployed. And that leads me to the collaboration with local providers for the mobile clinics. So while we're awaiting our final plans, I did want to give you a little bit of an outline of the collaboration. This is what I'd really love to hear from you today. So our goals are making sure that we're extending services to patients, and the patients who are not coming to clinic for whatever reason, be it transportation, be it lack of knowledge, be it having to work, etc. So how can we reach those people and then plug them back into the primary care system that is already established in the local communities? That's going to, like I said, require an integrated EMR so that we can hand off to local care and potentially for reimbursement mechanisms. So in terms of reimbursement or sustainability funding to keep the mobile clinics running, there's multiple options we've been looking at. I wanted to give a couple of examples. So when we talked to Lincoln County Hospital, they thought the easiest thing to be would be for the provider on the mobile clinic to just be credentialed as a provider with the Lincoln County Hospital system. Therefore, whenever we saw a patient, it would be just as if a Lincoln County provider saw that patient. They could bill through their system, and there might be some reimbursement for the service provided, but that it would all kind of stay in Lincoln County's system. Talking to Chaz in Spokane and some of the other, we think this would be equivalent for other community health centers. They thought that would be more difficult to try to enroll as a provider with a health center. And so they thought the best thing to do would be to be a contracted service for the clinic. So we could look at utilization, how many Chaz patients have we seen, what services we provide. We could look at over the time and we could say, okay, that is worth so much money, and then that will just be funds that help keep the mobile clinic going. A similar model was discussed with Molina, where we would have contracted services by the MCO. So for every diabetic eye exam that we're doing, that's helping the primary care provider meet their metrics. It's also helping the MCOs meet their metrics and the ACHs meet their metrics. So that's a service that's helpful, and so to keep that service running is their service. Molina actually has developed its own mobile clinic for the purposes of helping meet those care gaps, and they find it to be working very well in Spokane. They're interested in having us provide that service other places where they're Molina members, and we will be talking to other MCOs about that as decisions firm up from the board. The last thing I wanted to mention in terms of collaboration is an extension office program. So there are there have been calls across the country for, we should do for medicine what we did for agriculture with the extension offices as a way to make sure that resources are getting out to rural areas, that those rural providers are supported by university institutions. There are several states that have done this quite well, including New Mexico and Minnesota. And so the idea here would be, talking with extension offices about having a health officer. We talked with Jack Davies about this from the rural hospitals. And a health officer in each county would help us know in Spokane what is going on, what are the needs, what are the barriers being met, could help direct the provision of services for those mobile clinics, provide a liaison by which we're in the community and aware of medical care needs, student education opportunities, collaboration opportunities. So that's one idea, and I'd love to hear what you all think about that. So I will leave it at that, and hopefully we'll be able to have a good discussion when I'm able to join you on the phone. I appreciate your accommodating this mixed method conversation. All right. Thank you.
All right, Dr. Manriquez, is that you? I see coming online.
It is.
Great. And for those in your room, if you have a question, I just know we did mute all your mics. Make sure you turn your mic on. We'll turn it over to you. You're sideways, just so you know.
Oh, am I?
Yeah.
Let's see if I can get that straightened out.
There.
All right,
There you go. Excellent. All right, I'll turn it over to you and then open it up for questions.
Sure, great. So any questions I can answer, clarifications?
This is David Olson. I'm with Columbia Valley Community Health, one of the community health centers in the area. We have already, we're finishing a process that started about a year ago. We are going to purchase a mobile clinic in April. It's my understanding that Family Health Centers up in Okanagan County is also moving towards a mobile service. And my question is there any way for our organizations and the School of Medicine to maybe work out some kind of, I don't know what the relationship should be, but I'd hate for you guys to spend money to do something when two other mobile services are coming out here. I'd much rather partner or collaborate. Is that something you can see happening?
Yeah, I think absolutely. I mean, we're planning on collaborating with Melina, and Chaz has already shown interest in sort of a shared staffing model where they might want to have some of their providers on the unit when we're in areas where Chaz patients are being seen. So I'd be happy to talk with you more about that. That's actually the first time that's come up. I know Yakima Valley Farm Workers Co-op has units, but they're all in the dental area right now. So I'd be happy to talk with you more about that. And sorry, could I get your? I didn't get a chance to write down your name.
Well, it's David Olson, but I've got your information, and I can send you an email.
Perfect.
Thank you.
This is Sheila. Hi, I'm Sheila Chilson. I'm one of the other CEOs for the community health centers. And I think it would be good as you proceed if maybe we could have a conversation as all community health centers in North Central Washington. So just continuing on David's comment there, but I was hoping you could talk a little bit more about the integrated EMR, what your thoughts were on that. You know, what conversations have been held on that issue?
Sure. So our goal with the integrated EMR is essentially to be able to make sure that information is getting over to the, was one of two things. Either we can just have access to multiple EMRs, and then depending on how things are set up, we can document it in whatever local provider's EMR they have, or using the one that we have, which will likely be Epic, how we can port those things over. And there are some third-party softwares that are designed for making those connections, and so that's what we would look into more in terms of how to make those things speak to each other, and how to make that more than just faxing over things that has to be scanned in. What is the EMR you currently have?
We're on Simplicity. I know that there's just so many throughout this region. That's why I posed the question. You know, from Epic to Athena to Simplicity to just a multitude. So
Yeah, so it's our understanding that there are some of the people that were on the Epic development team left with Epic's blessing to create this third-party connecting system software, which I'd have to look up. But our tech center at WSU felt pretty confident that we could make those connections as long as there's data people on either end to link it up. It should be quite doable. So that's what we're looking at, the integrated EMR. I don't know if you've had any success or frustration trying to do that in the past.
that's a whole topic in and of itself.
Mm-hmm.
I've got a couple questions. Actually, that's wonderful thought, but it raises a lot of questions. I'm Jill Thompson. I'm one of the from Lakeshore Clinic, but I also live in Waterville, which is a Douglas County small community. So, looking at when you talk about the health officers at the WSU Extension, is that coordinated with the Agriculture Extension? Is that what you're talking about on that?
Yeah. So I think Colorado and New Mexico collaborate on their program. The New Mexico program is called HERO, and Health Equity Resource Officer, or sorry, Healthcare Extension Resource Officer, and they are similar to the Ag program. Their goal is to basically know what's going on in the local county, and then what information or supports can go back and forth from the academic health center. It's a little different in New Mexico because it's University of New Mexico Health Sciences, so they have their own hospital. We're a community-based medical school, so we don't have the same infrastructure as a healthcare system. But that's the idea that we're pursuing with the extension offices. So those conversations are still kind of early, but there's a lot of interest on both sides figuring it out.
What kind of licensure do the health officers have? Are those doctors, nurses, some sort of?
I think there are different levels of, and they're not doctors, but I think there are different levels of providers. I don't think all of them are even practitioners in New Mexico.
Yeah. The other question I had was about patient finding. Are you going to be seeking patients from Molina that aren't getting their care in a local way, or are you going to be just being out there and advertising, come see us when we're in town?
Mm-hmm. So I think that we're quite flexible on how we pursue that in each region, and I think that the bottom line is that from Spokane, it's not possible for us to understand the needs of all the different communities and then schedule meaningfully to show up and provide care. And so the best scenario is for local providers, for local community organizations to be able to direct that care and make sure that it's being done in a way that's useful. And so, that could be from the schools or from churches or from local community health centers, or the food banks or whoever it might be useful to make that connection. I will say that when we talked to the Rural School Nurses Association, they were very excited about the idea about having mobile clinics potentially coming back with their schools, but what gave them pause was the idea of having to add that organization and outreach and scheduling onto their already quite threadbare capacity. And so, that's one of the areas in which it might be really helpful to have someone whose role is to help make those connections. That's the idea of the health officer. That's one of the things they could be helping do.
I think we have time for about one more question, then we'll have to wrap up. Can you turn your microphone on? Sorry. Right at the bottom. There you go.
Okay. Just one quick clarification on how our banning token works, because it is everything Dr. Manriquez mentioned. But we also do for the gaps in care operation, we actually reach out to members. So we mail out to the members we have and try to connect with them every time the van will be in a specific location. And those members are selected from our gaps in care reporting, which says, show me Molina members that have not received this screening in the last 12 months. And that is the way we try to get to the rural areas for our metro.
Melody has one last question.
I'm actually commenting on behalf of Dr. Wallace. He could get through on the line. Just a couple of things. He wanted to make sure that maybe we can get contact information. There's several things that are really exciting to see how this could fit into some of the initiatives that we're doing for family health centers currently. One of those is to make sure that we're incorporating in our behavioral health integration into this program as an extension of what we're trying to do as an organization. And the other thing, one thing that piqued my interest is because I've been working with Roger on the empanelment issue. I think that's going to be an important factor as we're reaching out to these patients, that we move that into an empanelment opportunity for our patients. And then the last thing is Dr. Wallace is really committed to student interaction within our organization. If this is something that we could work on, a collaboration that would also be an extension of the school from the mobile units into our organization, so that it's a truly collaborative effort. That's something he's really excited about.
Great. So I think are you talking about health science students?
Yeah.
Okay. Yeah. So our goal, in all of the things that the WSU practice plan intends to do, it's an opportunity for education. So we would expect that there will be medical students, if not also potentially nursing and pharmacy, coming out with the unit, so that they're getting exposure to a different model of care and to rural areas, and seeing, just getting that exposure and seeing who else is out there, the most connection. So that's definitely something that would be going on with the unit. And then the broader picture of it, where we are in the Office of Academic Community Partnerships, making, getting MOU agreements with different partners across the state for preceptorships in the first 2 years, for clerkships in the third year, and for either required, because there's an urban or rural requirement in the fourth year rotation, or elective rotation in the fourth year. So there are definitely opportunities to connect more around medical education. And I think, as I said before, as a community medical school, we are actually dependent on engagement with local partners. And so it's something that we're putting a lot of focus and effort and attention to, and we'd be happy to follow up about the opportunities around those connections. In terms of contact information, the easiest way to get a hold of me is Luis, Luis, .Manriquez, MANRIQUEZ, @wsu.edu.
Family health centers just has acquired a dental mobile unit that's just within the last few weeks.
Great.
So that may be something we want to talk about sooner rather than later.
Mhm.
And then the goal is to have a primary care mobile unit also within the next 6 to 10 months probably. So the timing is fantastic.
Great. Yeah, that's great.
Great. Well, thank
I
you.
know.
I'm sorry, I'm going to have to wrap up because we have our governing board meeting coming in
Sure.
afterwards. But I thank you for sending out your email address, and I can send it over the listserv as well to everyone for those who were not here, so they would have it as well. I appreciate you joining us. Thank you for taking the time to do the presentation via PowerPoint and recording to accommodate your hospital schedule as well.
Great. Yeah. Thank you for the time. Sorry I couldn't be there in person. Thanks for accommodating this next thing, and I look forward to talking to you in the future.
Great. Thank you very much.
All right. Take care.
One last thing to wrap up is just to let everyone know that our next meeting in March is up at Family Health Centers in Okanagan. I have the address on the slide deck for those of you who want to make the drive up there. They make the drive down here, just saying, but there is no time for roundtable, so I'll say enjoy your day and stay safe out there on the slick roads.